And now we'll come to our next session. It will be in hematology. Let's invite our chairperson, Dr. Mona Burhamad, this consultant pediatric hematologist, and she's the head of the hematology department at MBK Hospital, along with Dr. Raj Rani. She's also our pediatric consultant in Jara Hospital. Please welcome to the stage.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the organizing committee for the nice organization headed by Dr. Fahed Lanizi. And also I thank them for choosing me to be a chairperson in this session. I am the head of hematology department and oncology in NBK Hospital. And I am glad to introduce Professor Chan. This is the second time for me to introduce him in a conference. Professor Chan, he is a pediatric hematologist oncologist at Hamilton Health Sciences and professor of pediatrics at McMaster University. Professor Chan is given the Career Investigator Award for Heart and Stroke Foundation 2005 to 2010, and currently holding the McMaster Children Hospital Hamilton Health Science Foundation Chair of Pediatric Thrombosis and Hemostasis. Actually, he has a long list of CV. I will try to summarize it. He is also the director of Pediatric Thrombosis Clinic and Hemophilia Clinic at McMaster Hospital. And in addition for the research about thrombosis and atherosclerosis and vascular stroke research. He is currently the chair of the Canadian Pediatric Thrombosis and Hemostasis Network and chair of subcommittee for perinatal pediatric hemostasis for International Society of Thrombosis and Hemostasis. Professor Chan is one of the leader experts in the field of pediatric thrombosis and stroke. He is continuing to contribute to the expertise in thrombosis by providing around-the-clock free consultation worldwide through the 1800 no-clot science services. Since his faculty appointment in McMaster in 1997, Professor Chan has published more than 180 peer review original manuscript and 55 review. So please welcome Professor Chan in his first session. It will be about CBC interpretation in pediatric.
Thank you for the kind introductions. I feel very at home because I see a lot of presenters have a FRCPC training in Canada. Almost feel like I'm actually just standing in Canada. Now, I changed the title of my presentation a little bit. I called it a morphological approach to the interpretation of the CBC. A lot of non-hematologists kind of worry about looking at blood smear because they found it's very challenging. But I tried to, first of all, remove that fear first, because looking at the blood smear is really just like recognizing a person. So hopefully over time, you can recognize me, you see me, I'm Anthony Chan. And no different from when you see this picture, I don't have to tell you what that is. You know the pictures, right? Yeah. And then if I cannot convince you further, this is a Canadian astronaut. So he took pictures from the space. And then more or less similar to looking down the microscope and looking at the blood smear. And say, for example, I'll show you the next picture. You recognize it right away as well. Right? You don't need anyone to tell you. If you see it once, you know what it is. So the first thing about blood smear is you have to look at it and recognize the fact that it is a good blood smear. Say, for example, for all 6 smear, this is the only good one because it is evenly spread. The one labeled as F, that is evenly spread, and that will be a good smear for you to look down the microscope. So the first one is, I'm going to give you pictures, at least a few of the cells that you will see under the microscope, and then you have a sense of that. Say, for example, this gives you the picture of the neutrophil. The pointer doesn't work that well, but you can see it over there on your left-hand corner, neutrophil. Eosinophil and basophil essentially describe the color of the granules within the white cell. Basophil stands for the fact that it looks slightly blue, and eosinophil looks a bit red. And then there's the mononuclear cell, which is the lymphocyte, and the monocyte at the bottom of the graph. So once you hear the descriptions, I'm pretty sure when I showed it to you, you'll be able to recognize that cell. Once you recognize them, all you need to do is associate it with what is the disease, if it is increased or elevated most of the time, or when it is a decrease, depending on the situations that you're looking at. So when you look at the picture on your left-hand side, what would you think that is? Because the granule looks quite red, isn't it? So that would be an eosinophil. And then when you look at the to the right-hand panel, to your right, the granules within the cells has no color to it in some way. So those are neutrophil because of the neutral color. So you'll be able to recognize it right away. And I'm going to show you the next picture. The ones that is with the arrow on them, all the granules looks blue. And so that becomes a basophil. A lot of it, we actually have learned it in the medical school already. Basophils, in most of the times in pediatrics, has fairly little relevance for us because there's not a lot of disease associated with elevation of basophils. So those are rare. Eosinophil, a lot of times we associate it with parasitic disease, or at times there's something called a hypereosinophilic syndrome, and in rare situations, you may actually have leukemia associated with eosinophils. Now, in terms of the neutrophils, most of the time when you think about it is related to infections that you see, and I'm going to show you the next slides. When you see those characteristics in the neutrophil, a signal to us that is the neutrophil is activated and associated with infections. These are the vacuoles that you can see in those in the neutrophils, and you can see it, there are kind of holes in them. So when these actually appears, it suggests to you those cells are activated and is reacting to infections, particularly bacterial infections. Now, these, can you actually see the difference between these white cells to the ones that you look at the prior slides? One, these are actually mononuclear cells, and second, when you look at these nucleus, they're more homogeneous or spread out, and these are, can you give it a guess in your head what you think that is? These are blasts, so these signal that these are leukemias. On the right-hand side, it will be acute lymphoblastic leukemia. On the left-hand side, it's more on the acute myelogenous leukemia. And there's some characteristics in the AML, and most of you actually will remember when I show you the next picture. I keep the picture on the right-hand panel to be the same, and on the left-hand side, you see some extras in those myeloblasts. You can see there's some rods over there, and these are our rods. So these signal to you, these are AML. Now, when I'm actually on call as a pediatric resident, one of the things that I'm almost kind of dreaded to try to differentiate, are those blasts or are those atypical lymphocyte? Because there's atypical lymphocyte, a lot of time is associated also with ITP, because the patient have low platelet count, and then you see some abnormal cell. The question you ask yourself is, are those blasts? Because if that is the case, I actually have two cell line abnormality. Most of the time when you think as a hematologist is, if two cell lines are involved, it's at the time to do a bone marrow and to rule leukemia. But the good part of it is, whenever you look at the cells, most of the time you don't actually have to look at one cell at a time. You actually have to look at the entire context. So you look at the history, physical examinations, eventually looking at the smear. If the patient gives you a history of prior viral infections, and then with a thrombocytopenia, otherwise normal child with no hepatosplenomegaly, and you just see a cell like this, And when you can see, although it's a lymphocyte clumped together, they are not like the blast, as you can tell from the left-hand panel. In contrast to the right one, the nucleus is more homogeneous. So on the left-hand panel, that will be the atypical lymphocyte. On the right side, that will be a lymphoblast. And so when you actually interpret those things, you have to take into the context both of the history, physical examinations, and the associated features. Now, this is talking about the lymphocyte, mononuclear cells. At times, you also see inclusion bodies. Yesterday, when the sessions presented about immunodeficiency, remember the Chidiac-Higashi syndrome. The smear on your left-hand side with the inclusion bodies, that will be the inclusion bodies presented in the Chidiac-Higashi syndrome. It's a really large inclusion bodies. In fact, the first Chidiac-Higashi syndrome patients that I diagnosed, in fact, was not even diagnosed by myself. It's actually diagnosed in a laboratory, a hematology laboratory in a small town with only about 20,000 persons living in there. But the technicians can recognize these, the inclusion bodies, and the technician make the diagnosis. So at times, knowing those diseases is actually very important. In contrast to the smear on your right-hand side, you can see those inclusions bodies. These are related to some of the metabolic disease that is mentioned earlier. They were inclusion bodies in the lymphocyte, but they are substantially smaller. Now, coming from the white cells, I go to the platelets. The platelets, at least I'll show it to you, is on your left-hand side, these are platelet clumps. If you see a platelet clumps like this, in the CBC, you may actually have a thrombocytopenia, but those are not real thrombocytopenia. You can say pseudo-thrombocytopenia, related to the fact that when the platelet clumps in your smear, signal the machine will not pick up the proper numbers of platelets in the automated CBC. Another phenomenon is like the one on your right-hand panel. These are satellitism. In some way, the platelets stick around to white cells. Again, in those situations, your CBC will give you a false low thrombocytopenia, and the platelet count will essentially be normal. In the next few slides, I try to contrast a few things within the platelets. One is the staining of the platelet in terms of the color, and second is about the size of the platelet. Because looking at those characteristics, you will be able to diagnose some of the disease as well. So in this particular, on the most far right smear, can you see the platelet count there? The platelet there, that is very large, isn't it? It's almost to the size of the red cell. So these are giant platelets. And for giant platelets, there are some hereditary thrombocytopenic syndrome that is associated with it. Say, for example, Bernard-Soulier syndrome or Glanzmann. And those are also associated with thrombocytopenia. In other situations, say, for example, with the platelet being destroyed, like in ITP, although the platelet count will be low, the platelet will also substantially larger because in general these are young platelets. At least conceptually, we feel these young platelets are more active. If you have a patient with very similar platelet count but thrombocytopenic, patients with a large platelet seems to have a better hemostatic mechanism because these are young platelets and seems to be functioning better. The blood smear in the middle panel, and these are normal sized platelets. Okay, so relatively speaking, they are quite a bit smaller than the red cell in contrast to the left. Once you have the contrast, you appreciate the size of the platelet is very different. The smear on the most left-hand panel is the one with small platelets. Again, you may remember the presentation yesterday about immunodeficiency syndrome. Wiskott-Aldrich syndrome. Those also comes with a very tiny platelets, And then you can actually pick it out from there. And you also see the number of dots, which is the number of platelets. Relatively speaking, is lower. So in Wiskott-Aldrich syndrome, you actually have thrombocytopenia as well as small platelets. In this particular smear, it's tried to impress on you about the staining of the platelets. On your left-hand panel, the platelet stains somewhat kind of blue and eosinophilic, as I showed it to you in the last slides, and they're also large. In contrast, the one to your right-hand side, you say, wow, the platelet color is quite a bit different. In fact, these are related to the fact the granules in those platelets are absent. So there are granules in the platelets, which I'll show you in the pictures in next presentations. At times when these places are degranulized, it suggests to you that the samples of your CBC is not very good because the platelets is activated and degranulated. If the sample is good, it suggests to you that the patient may have a hereditary platelet disorder called gray platelet syndrome. These platelets are created with no granules in them, which also means they do not function as well. This particular slide, this last slide is about thrombocytopenia. On your left-hand panel, it shows you they are platelet of variable size. At times you see it with patients with hyposplenism or splenectomy because the platelet is not being taken up by the spleen in the various fractions, and then platelet of different ages, you can actually see them on the smear. Now, I don't mean to go through this graph, but I just want to show it to you. These are very good resources by looking at the platelet size to help you. On the right-hand side of the slides, you can see there's a large, normal, or small platelet in order to help you to get to the diagnosis of thrombocytopenic patients. And you find these particular figures at the website by the Association of Hemophilia Clinic Director of Canada, and the publications is published at the website. In terms of thrombocytopenia, I just want to pause, and then I will refer to these particular conditions in the next presentation. Is about ITP. Most of the time when we see a well child with a low platelet count, we'll automatically think about ITP. However, at times, especially when those patient doesn't respond to therapy as you expected, that congenital bleeding disorder you have to think about. Say, for example, I mentioned earlier, like a Bernard-Soulier, a Glanzmann, or type 2 von Willebrand disease. All those come with thrombocytopenia as well, and they will present to you as a bleeding disorder. And these are, in fact, megakaryocytes, which you will not see in the peripheral smear most of the time. What I'd like to demonstrate to you, the megakaryocyte on your far left side are the ones you can see with the megakaryocyte with the platelet coming off from the cytoplasm. And then as you go to your right-hand side, these platelets in some way, megakaryocyte, become more mature. This particular slide shows to you some of the inclusion bodies that you will see in the neutrophil. Say, for example, the one on your right-hand panel is the May-Hecklin anomaly. On the left-hand panel, I apologize, I have to kind of adjust. And then you can see these, as I said earlier, also with large platelets. You can see the platelet that is relatively large. In contrast, there are other situations, mostly a benign conditions, but you recognize it is the Dolly bodies on the right-hand side. Now I'm going to come to the red cell. Some of you actually have rings, right? It's great to have diamond rings or rings on your hand to let you remember something. However, if you see some of the rings in the red cell, and that would not be nice. You can see it in the... are you able to see the rings in the red cell? So most of you will remember, these are malaria. So one of the things to look for under the smear when you look at red cell is look at whether there's red cell inclusions. So one of the characteristics you're looking for will be red cells inclusions.
And these, you have 4 minutes.
Yeah, that's great. These are malarias, and these will be Howard-Jolly bodies, okay? Howard-Jolly bodies, you will also see it in the patient with splenectomies, and then on the left-hand side, actually that would be with hypochromic microcytic anemia, also with some target cells. Furthermore, you may be able to see bacteria or parasite in the smear, as you can actually see in this particular area. You will be able to see sickle cell. I think it's just as it's described. And in here, it actually contrasts to you from the right-hand side. It would be a hyperchromic smear. In the middle, it is a normal, that would be a hypochromic slice. On the right-hand panel, that will be a normal. And this slide demonstrates to you the size of the smear. On the left-hand side will be the macrocyte with a hyper-segmented neutrophil, suggests a vitamin B deficiency. And the first on your right-hand side, that will be a hypochromic microcytic anemia. Mostly you have to remember about iron deficiency. Of course, the MCV, which is the size of the red cell, changes over the ages. And one way to differentiate a smear is looking at the MCV from low MCV to normal to high. And I think the key thing to remember is iron deficiency anemia, thalassemia, and anemia of chronic disease in the low MCV. On the normocytic anemia, you have to think about whether there's blood loss or hemolysis, depending on whether the reticulocyte count is high or the reticulocyte count is low. We suggest to you whether there's inflammations or medical causes. On the macrocytic anemia, that would be, all of you remember, B12 or folate deficiency, and then if they are non-megaloblastic, you have to think about hypothyroidism or liver disease. Hopefully, alcoholism is not a problem in children. Of course, there's automated machines that will actually help you differentiate the size of the cells. These will, what you'll be mostly seeing in the machines that in most countries. However, there are new machines that will even give you the immature fractions of the platelets and the immature fractions of the red cell that will help you to differentiate whether platelets, say for example, is destroyed, or whether the red cells is produced in a fashion that corresponding to the hemoglobin. This particular smear shows you to have a patient with a low ferritin with some hypochromic microcytic cells that suggests to you as a iron deficiency. I just have to remind you, patient can have an iron deficiency but still with no anemia, and those are very important to treat because iron deficiency without anemia may still cause a neurodevelopment and behavior problem that cannot be reversed. Okay? Last but not least, in the hypochromic microcytic anemia, these are basophilic stippling in the red cell that suggests to you as a lead poisoning. And I'm going to finish my presentation here. And this is, you can recognize a maple leaf, but it's in fact, it's taken in space, it's floating in the mid-air.
Thank you very much, Prof. Chan, for giving us very informative and very interesting talk on numerous slides which have refreshed us throughout the years for the peripheral smears, which we are waiting for so many opinions so many times in our day-to-day practice. Now, since there are lots of questions, but you are going to be speaking on the next interesting subject, how low can they go? That is thrombocytopenias in children. And this is also our very common problem day in, day out. I'm sure Prof. Chan is going to throw recent updates on that. Thank you very much.